Good morning.
Morning, Matt. How are you?
Good. How are you, Laura?
Doing okay, thanks.
I hear you are pinch hitting today.
That I am, and I'll do my best.
I'm sure it'll be great. It'll be a good discussion.
Thanks. I really enjoyed your piece in the newsletter, by the way.
Oh, thank you.
Yeah, and I sat there thinking, when he says, the story, and I was like, what story? And I read it. I was like, actually, I don't know that story, so I very much enjoyed it.
Oh, good.
Yeah, thank you.
Hey, everyone.
Hey, Max.
Hey, Max.
How's it going?
Good, you?
Good. Doing well. The air conditioning went out in our hallway here, and it's about 1,000 degrees outside, so that's not a good combination.
I'm sorry.
Other than that, chipper. All right, so we'll wait, obviously, for Ruth to get on, and I will then just at the beginning do the agenda and presentation intro, and then we'll just ask the questions and make it kind of open-ended.
Great.
Do it that way.
Thanks.
All right. And Matt, I'll probably share the screen both for the agenda and then the PowerPoint, and then I'll take it off, and then the rest of the time we can just do open discussion. That works.
Yeah, that sounds good.
Okay.
Looks like Ruth is here. Welcome, Ruth.
All right. Okay. Let's see. And I just realized when I sent out the link that I don't know if there was a hyperlink clicked on. I know Dan sent his out and it worked. So, well, maybe a few people will call in as well. Get that going.
Yeah, it's always nice to keep the phone option. Some people are driving or
Right.
they like the phone.
Exactly. Give me 1 minute here. I'm just gonna get things together. One second. Okay.
Hello.
Hey, good morning.
Hey. You see me?
I'm gonna click off of
Hello, Sean.
How are
Hey,
you?
good morning, John.
Hey, there he is.
Hey, oh my goodness. Matt, are you growing a beard?
I shave it every Sunday, but yeah, this is my end of the week beard.
You're looking wiser by the minute.
I prefer wiser than older.
You got it. You got it.
Yeah, I don't assume John the mustache is coming back.
No. No.
Yeah, not anytime soon.
Not anytime soon. How are you?
All right. Well, we can get started here. I know a few people will probably be chiming in a little bit. Thank you again, Laura and Ruth, for the last-minute adjustment for topics. A little diversion from the original topic, but that's okay. That's why we're all collaborative. That's what this is all about. So, or me, maybe forcing you both, but that's okay to do it. But no, I'm kidding. So, I will. Let's see here. I'll share my screen here. Okay. Can you see? You just see the agenda?
I can see it.
Yeah.
Okay.
Yeah.
All right. So we'll just quickly go through that just as far as some updates with the SIG. And then give the introductions to Laura and Ruth, and then we'll start the discussion. So just some updates going on with the conference. As you may have seen, a few updates on things. We have a combined dinner and meeting the night of Thursday, October 17th. We think this will be a really neat combination at the conference and a way to get more people there, but also be right in the hotel. So Jackie and I are finalizing some things with the Yard House in the hotel, but Dan Blocker sent out a recent poll, and if any of you haven't been able to just take it real quickly, click on the link. We just want to know some information, how much people are willing to pay for the event. We didn't put an option for $100. We were hoping, but that didn't work. But people are willing to go as high as 35, which was kind of the average spot for it. We'll probably have a little bit of light food. People will be able to get like a drink ticket and all that. So it'll be a nice way right after the plenary and social hour. We can go right down into the restaurant area. So we're just finalizing a lot of that. But I assume that the majority of the people on the call here are A, going to CFHA, and B, will be there Thursday night. I take it. Okay.
Yeah.
Heads are nodding. That's good. All right. The yearly Families and Health webinar. This will be exciting. We went through a lot of different topics, and we talked about just workforce development and training the next generation of professionals. So Randall, Matt, and Gina will be given a really neat kind of collaborative webinar August 8th, 1 to 2 p.m. Eastern, 10 a.m. Pacific time. And it'll really go over kind of a workforce development need across different levels of training. So actually today's discussion will be a good kind of primer for that. They want all the SIGs to do a yearly webinar just to advertise some of the things that are going on across the SIGs. So we'll have that. So put that on the calendar if you're able to make it. And you'll get more information from there. Newsletters. I think everyone or most people are able to see the initial launch of the newsletter.
Right.
I know there's been some pretty good reception from it so far. I assume I haven't gotten more global feedback, but people thought the first run through was pretty good.
Yeah.
I read it. I liked it.
Great.
Yeah, that's good.
What kind of things?
I know what sections you read, Matt.
What kind of things would you like, Max? What kind of things would be really mean what we're doing, or? Yeah,
we're going to pretty much run through the same sections that we did in the newsletter. So I would kind of give just a intro at the beginning, just about the SIG, and then there would be like a blog piece, what Matt contributed. If there's a case study or experience in the field that Tyler was able to provide, a professional in the spotlight that someone would be able to just refer or give some information for acknowledgement. So we'll just keep those sections consistent across every quarterly newsletter. But really the main thing, the blog piece is something where a longer writing sample on pretty much anything. So similar to the CFHA blog, something that's timely and useful would be helpful. But we're at this point open to any and all contributions. So, but great, yeah. And by August 15th, if you have an idea, feel free to email it over to me. And then Leanna, who's done a great job at CFHA, will be able to put some stuff together for it and put it together. So the last thing that the SIG has talked about, and this is still in kind of the works, is the idea of maybe having a conference scholarship in the future for people, mainly interns or a few students, whether new to CFHA or want to present their research, to have a little bit of scholarship money to attend the conference and to get periodic mentoring from a mentor in the field. So I will probably be talking to some programs in the next month or so about any small contributions. I think this will be a collection of money that'll be contributed, and hopefully if we get a little bit of money at the conference, we can maybe roll this out. And even if we start with one scholarship, we can do that. But I think it's a neat way for students to get a little bit of funding for the conference and an incentive to do more research. And the research and evaluation committee will be evaluating the applications. So it's not us looking at all of them. But
Max, can I ask, how are you thinking about funding this again? Did you say you would be approaching programs or individuals, or how are you thinking?
Well, we're thinking programs first. So graduate programs who want to almost be kind of co-sponsors. So when Jackie and I spoke, and I spoke to Naftali about this a while back, possibly we could get, I don't know if it'd be like a table, but a little bit of advertisement at the conference, or even just some brochures around, this could be an option to apply down the road. But yeah, we'd be looking at programs to donate a little bit of money. If they're independent donors that want to put in a little bit of money, that would be great too.
Yeah, I would recommend making, there's a list of some of the senior folks, not seniors, senior folks, that have been in the organization for a long time. Some are not as active now, but I think that would be good. The other question is, would CFHA be willing to match any contributions? Is there anything like, I don't know what's in their coffers these days, but I think they're doing pretty well, but I don't know. Or is that not a realistic?
I don't think Jackie's on the line. That may be probably more in her area. I don't know anything about the budget or their funds. That's a good idea. I think that ideally if it's outside money that's coming in, and like, I don't know if there's an incentive as far as a tax deductible contribution into this, that's incentives for programs or donors, but that's a good idea. I could check with them to see if there's a matching process.
Yeah, I guess my question is a little bit broader too. I don't know what CFHA, what the board's doing these days in terms of reduced fees. That's like a subsidy too. Is there a reduced fee for student members, or is there any additional scholarship that wouldn't be specific, let's say just the family and health SIG, but also could be PCBH, one of the other, a little bit broader. I don't know where the board is on that. I'm just curious. I think it's important. I think it's important to, facilitate, obviously we'd all agree, bring, younger folks in who are in their training.
I completely agree. I think we have tried, and I don't know, in the past, trying to get the student fee reduced. And that's been talked about. That's all I know in those meetings. And perhaps Randall or even Deepu or some of the current board members probably know a lot better as far as the discussion, I bet. But I can check into that and just see.
Jackie just joined the call, so she may be able to speak to the process that we'd have to go through to pitch this idea to the board. I think it's a good idea. I think CFHA would be interested in supporting some kind of scholarship or discounts for students who have scholarship that they want to present. I know here at ASU, we might be interested in helping to support this as well, and I think there are other schools interested.
Yeah, and it would, to get Jackie's thoughts for sure here, it would be a really nice kind of advertisement, I think, not only for the scholarship, but I think for programs and just kind of like a smaller collaborative effort to get this going, and even just highlighting some things of the program at the conference. But
I know, last thing I'll say, AFTA has done that for years, where it was actually diversity scholarships where people can donate at the end of the year specifically if they want to give to that fund to support It's for students. Well, it's not actually specifically even for students, but it's diversity, people who are working in public sector who just don't have the incomes to come to the meeting. And it's been very successful. They usually sponsor about 15 people coming a year. And it on a whole bunch of levels, which you can imagine, it really enriches the meeting. It also brings in different kinds of membership, et cetera. So, but there is a space at the end of the year where you can make when you renew your membership, you can make a contribution specifically to the diversity fund, and everybody knows that goes to scholarships.
Right. That's another really good idea too. So I figured that could increase donor response as well, not just from the programs, but yeah, real quick, Jackie, and do you have any information as far as we were talking about just student fees for the conference, and also I don't know if those were looking in the future to get reduced a little bit, and we've been talking this kind of dovetailing into the student scholarship idea for the conference, or how people could contribute more to students. Maybe Jackie's not there. Okay.
She's there, but her microphone might be muted.
Oh, okay. All right. Well, Jackie, if you want to chime in at the end too, when we just review and wrap up some stuff too, if you have any thoughts on that. Otherwise, I know we'll be able to talk offline for a little bit as well. And
I had one last thought about that too, Max.
Yeah.
So if you did two different funding opportunities, if you were to have one, a scholarship for master's level students and another scholarship for doctoral interns, my thought in regards to the doctoral intern scholarship is that maybe the sites that offer doctoral internships may want to donate towards that as another form of marketing. I know for me, I would certainly write that into my budget. Right.
That's a great idea. I think even splitting up MA or PhD could be really good. Yeah, that's exactly what I was thinking, was just from a marketing standpoint, from the grad programs, the fellowships, from different places. It could be great. And again, if we can get a table at the conference, even to promote it, or have some brochures from places who are a part of that, that could be really neat. But yeah, I think even getting in the MA students or master's level students could be a really nice entry point for people looking at doc programs or looking at integrated behavioral health in general. So excellent. Well, I don't want to cut the time too short from the presentation. So again, the next meeting will be August 9th. There'll be the closed meeting for the SIG group. We'll have our final open call in September, where we're just working and finalizing some topics for there. And then after the conference, I'll be passing the baton off to Stephanie. So, all right.
Hey, this is Jackie Hahn. Can you guys hear me now?
Oh, hey.
Hey, how are you?
Good.
I'm actually in Missouri and working from a hotel room, and obviously I wasn't doing it well. So, so you guys were talking about we're starting a scholarship for students. Is that what you wanted?
Yeah, real quick, we were talking a little bit about funding students or a few students for the conference, and if there's programs or fellowships that can contribute a little bit to it, and where it not only reduces their fee, but it encourages more research and scholarship applications for the conference. But there's some good thoughts from the group as far as what other forms of donations and sponsorships could happen, but didn't know if you had other thoughts on that as well.
No, I definitely think it's something we can do. We could add something to, like if it was something you wanted to add to the registration form. We probably have to run it all by the board, so it may not happen for this year, but we can, talk to the board and see. Otherwise, sometimes organizational memberships we've changed those so that students, you have an unlimited number of students on there so they can get the membership. And then they can get the discount at the conference, which can bring it down to $259 if you come to the conference as a student. So those are a couple options we have already.
Okay. Yeah, I think we can try to be creative as far as different ways to contribute to it and reduce. I'm sure there's been discussions in the past with student fees for the conference, so I know that would be a whole nother discussion in itself, but yeah. Okay. Excellent. All right. I did make a intro slide or a few slides for Laura and Ruth.
Nice.
We had to work this on the fly, but I figured that teaching family-centered skills to learners would be a good topic. And again, very happy that Laura and Ruth were able to fill in and talk on this. We want to kind of make this more of an open discussion with both of them, more of a Q&A, and I can facilitate some questions. Definitely want others and make this more of a discussion at the end, maybe give 10 or 15 minutes, just get everyone's perspectives on things and where it is going forward. So here's Laura's information. That is all correct.
It
Welcome
is.
on the call, know her. Assistant clinical professor, family medicine, public health at UCSD, licensed MFT, did her training fellowship at St. Mary's in Grand Junction, working with Randall. And Ruth, director of behavioral health at Ascension, clinical assistant professor at KU School of Medicine in Wichita, licensed MFT, and did fellowship training at University of Nebraska, GIM. So hopefully I had that information correct. We need to make a official introduction there.
Yeah.
I will stop sharing that. All right, so wanted to just bring up some questions here and to Laura and Ruth, kind of start the discussion off. Talk a little bit about your background and training in family-centered skills, and kind of bring us up to speed to now, you know, what you learned through your training and kind of how it's helped your kind of your current job to this point.
Do you want to go first, Laura? I'll follow up.
I can take a stab at it. Yeah. Well, thank you very much, everybody, for being here. And I think many people on this call, I'll speak for myself, I've been influenced by in terms of how to implement family-centered or family-oriented skills. And probably Ruth, as an extension, you might agree with that. But so just by way of background as well, you know, I came to USD for my master's work, as Max said, and that was more of a biopsychosocial spiritual approach to treating patients or clients or people within our different sites. And so it still was somewhat of a traditional program. And then when I went to Virginia Tech, still that was a very traditional MFT program. There wasn't a lot of this emphasis in behavioral science or family-centered, family-oriented skills. It was still from the, you know, good old structural family therapy, strategic family therapy models. And it wasn't until I went to my fellowship with Randall that I started to get exposed to things like agenda setting, the things like how to really adapt and adopt these classic traditional family-oriented skills into the medical environment. And so that was really like my first entry into true interdisciplinary training and learning about the intersection about these traditional skills and how to really adapt and implement it into the primary care environment. And then I think the majority of my experience in learning about these skills is through groups like this at CFHA. I think it's also through different conferences and going and seeing people talk like Matt Martin or John Rowland or Max Zubatsky here about, you know, models that we can help conceptualize families' illness, and then what are the specific skills, and you know, influenced by the work like with Dan Felix and Larry Mauch. So I hope that's helpful in terms of like how I've really come to figure out how to implement some of these skills in this primary care environment, and also how to teach this to other medical learners.
So my story is similar. Laura and I are actually fellow Hokies. So did my PhD as well at Virginia Tech in human development with a specialization in marriage and family therapy. And so when I started my doctoral internship at the University of Nebraska Medical Center, it was my first time being exposed to integrated behavioral health. So there was definitely a learning curve. And I was really thankful for the guidance that first Katie Cooney and then Jennifer Harsh provided me in transitioning through that. And I was in internal medicine. And so within internal medicine, behavioral health providers were definitely appreciated and accepted at UNMC, but there was not an emphasis on the family system. So I was thankful to be able to pull from my background of being trained within family systems and conversations that I had with both the behavioral health interns as well as the internal medicine residents during that internship and then fellowship really revolved around, who are the individuals coming to these encounters and how can you incorporate more of a focus by either bringing other family members or friends into those encounters or at least discussing, those family members and friends within assessments and intervention. So broadening that scope from the individual to the family and social context.
Mm-hmm.
And that's something that I continue to really strive towards, even now being in a family medicine residency. I think a lot of times we take for granted, well, they're trained family medicine providers, they're going to think about the family system. But, our residents have so much to do, so many boxes to check off that they're not necessarily expanding to think about the broader context.
Yeah. And that kind of transitions into the kind of follow-up question that both of you, not only being Hokies, having that background, but also just through grad school training, what was something you didn't learn in grad school that you had to really learn on the fly? In regards mostly with, I guess, teaching, whether it's residents, med students, medical learners at your site that you don't normally get in grad school. For those watching this webinar later on that are instructors can take with them early on.
Mm-hmm. Ruth, would you like to take this one first?
Sure, I'll go first this time. So yeah, honestly, coming into my position as Director of Behavioral Health within the Family Medicine residency, I had to develop a longitudinal behavioral health curriculum on the fly. We certainly did have a behavioral health curriculum at UNMC that I had learned a lot from and it helped develop. But when I got here to Ascension Via Christi KU, I wanted to quickly create a curriculum that met the needs of our family med residents. And so obviously looking at ACG requirements, looking at, discussing with other faculty and residents about what areas they felt that they had received a lot of training on, other areas that they had not received training on. And I've specifically done surveys of our family med residents to help identify the gaps in the behavioral health curriculum. And I also get the yearly feedback, the evaluations. And so that has helped me, now 3 years into my career, to develop a fairly structured 2-year behavioral health curriculum that is really focused on collaborating with other mental health experts. So, for example, if I'm presenting on bipolar, I will usually have an hour session where I'm presenting based on assessment, diagnoses, intervention, and then the following month I will have a psychiatrist come in and talk about how to manage bipolar through medications. Or if I'm presenting on insomnia, I will co-present with a PharmD to talk about treating insomnia if necessary through medication management. So really identifying the gaps and then filling those gaps with collaboration among other mental health experts.
Mm-hmm. Yeah, I echo that. And I think for me, a bit of a complicated response is how to connect with these medical learners. I think for us as behavioral health providers, mental health providers, or whatever term is most comfortable with you, is I think we get it, we get the value, but then once you go into the context of working with medical students or residents, you have to figure out a way, right, to kind of get into that or enter into their world to say, this might be important. So, hopefully you get something out of it. And that's something I didn't learn in graduate school throughout those years. And so, I found just presenting the material to be a bit lackluster, even if I married it with a case study. And so it was hard to find a way to really create opportunities for this openness and learning. And so what I've kind of done, and I'd be interested to hear what others do as well, is that I kind of set it up to say, there are more or less 3 buckets of learners. I think there's one who come in and they say, this is an important part of my medical care and I get it, I just don't know how to do it. Then there's kind of the middle bucket that says, I kind of see the value in it. I'm not quite sure about how to do it, but I'm ambivalent. And then there's like a third bucket, which might be, and forgive me, like, I don't want anything to do with this, right? I just need to know how to medically manage this patient and then to patch them up and then ship them off. And I try to meet them where they're at and just let them know is no matter what bucket you're in, that's fine. I'm not here to force you into this one over here, but that hopefully as we're like going through, you can see maybe perhaps some value in incorporating some of these family-oriented skills to get the most out of your medical visits to help your patients. So that was just one area.
You're probably wanting them to dump their information in one particular bucket, I'm sure, but it's a learning curve for many. But so speaking on that, those are good perspectives, and I think kind of differ in their own ways. So what would you say were some breakthrough moments for learners that you've had so far in your career, where maybe it was something that surprised you, or a teaching moment that was a breakthrough for a resident med student, intern, behavioral health provider? That was really neat.
Yeah. So at the end of each session, and session I'm using as a broad term, could be like a lecture at the medical school or with our behavioral science clinic with our residents, or even teaching evidence-based practice at University of San Diego. I asked for 3 nuggets at the end. And so teaching the medical students, there was one situation where I was talking about family-oriented skills, family-centered interviewing and how to do it. And granted, this is eliciting, not like a spontaneous enactment where somebody said, oh, remember that time when you said X, Y, and Z? Well, I did it and it was helpful. But then, there was one time I was giving this lecture that I do every year to the med students and asking for nuggets. And one of them did share it to say, I never thought to really ask questions like, who else should be in the room that would be important? What would they say about the treatment plan that we've created today? And I give the example of you can work with your patient in the room and create that treatment plan together, and then they can go off and then call their son, who's an RN in Wisconsin, and their son can say, I don't agree with that at all. And then what happens to that treatment plan is that you don't have a follow through on the patient end. So the students share that was really something that they haven't thought about before, and they can see it as a value-added question that would help them in their clinical cases. So that, for me, I think was the more of a memorable moment in teaching that I had with medical students.
Yeah, that's great.
So I think there's 2 thoughts that come to my mind. I think one of the most teachable moments and meaningful moments for me as faculty is just recognizing the importance of making education presentations applicable and tangible for our residents. And so I've really, going beyond just being interactive and having activities, I really try to have case studies where they can apply what we're discussing that day. So whether it's on mandated reporting or utilizing brief intervention for anxiety, I've noticed that those case studies engage them very well, and they can apply that to what they're doing in the clinic. Residents want the time that they spend learning to be useful in the brief moments that they have with patients. So I try to really formulate my presentations around how residents can utilize that information with patients. And then the second area that has also stood out to me too is that is engaging emotion. And a lot of times when we think about medical learners, we may assume that they're adverse to emotion. But I've found that in the presentation where, you know, if I'm presenting on bipolar, sharing someone's story, you know, someone not related obviously to the residents, but sharing a story, making it somehow personal for them, they seem to remember and take away more from those presentations where they're engaging emotional aspects as well. And I always have kind of tiptoed around that by not wanting to be off-putting. But when I do presentations or teaching and during the evaluation, that's when I've reviewed really positive feedback about making them think about diagnoses and mental health disorders in other lights and making them understand the patient perspective even more.
Mm-hmm. Yeah. Well, I'm sure on different levels, both content and just what you get expectations wise from a teacher and instructor can be far different than when you go into it and what you believe in there. So has there been one challenge that stood out, and maybe particularly around family-centered skills? Because I know both of you in some capacity have worked with residents, different types of students, different levels, teaching the concept of family itself. Anything that's come up that's been challenging, interesting, frustrating?
I think what I've seen within our residency, especially in the past year or so, is a greater emphasis from residents on really setting collaborative goals with patients in regards to behavior changes, health-related behavior changes. But I'm still trying to stress with residents what it can look like and be like to incorporate more of the family system into that goal setting. And so whether, you know, it's identifying individuals who will help facilitate that behavior change or may, you know, pose some barriers to that behavior change. How can we involve family members, especially if they're in the room, or how can we at least have discussions with our patients about, okay, who do we need to think about? Who do you need to talk to about this goal, and how can we get them on board to help make this goal a reality?
Mm-hmm.
That takes time, and we don't always have that in busy clinics.
Right. Very true.
Yeah, and I think this question, I come at it from an implementation of the curriculum standpoint, because being part of different residencies, there is sometimes historical precedence to say, oh yeah, the person before taught these types of skills. But you might be in some residencies or medical environments where this is not part of the curriculum. And so I think that the implementation of it, you have to just be mindful of that context. And sometimes it just really boils down to the logistics. And so if you're in a setting where, like for coming here to UCSD, where there has been some family skills implementation in the medical school, it's quite easy to like kind of look at that curriculum to see what are maybe the gaps and holes that to help improve that. Whereas maybe in another example for behavioral science clinic, we have each week we have residents who are really focused on their differential diagnosis when they bring patients in and utilizing their SIG caps. And so with that, it's figuring out how to really balance that with, which is what they absolutely need to know to help the patient to see what's going to inform their medication management, but then also how to marry that and have family skills to be just as important in that clinical encounter. So I think it's the logistics and setting those expectations within each context appropriately, and knowing as just an educator, like what is doable within your setting.
Mm-hmm. Yeah, it's interesting. Both of you brought up just small steps of implementation or concepts in the room all the way to larger, more macro things of curriculum and organizational structure. So there's varied layers as far as some of the challenges there. I want to ask the last question, and then maybe we can open that up to the group as well afterwards. Why do you think maybe some places still don't value family-centered skills approaches? I'm thinking more so even in our healthcare system, not just in our programs you come from. I know this is a very large monster question, but maybe get some perspectives from both of you, and then have the group kind of chime in on that one. But any just kind of more global thoughts on why it's so difficult through training or just through these organizations where we're missing some of these pieces?
Mm-hmm. Well, I guess I'm reminded of the newsletter that just came out about, how do we even define this and talk about it with people? And I think, there's that one concept of like, how do we really think about it? Do we think about more expansive, which is just an orientation? Do we think about it more as a model or whatnot? But I think it's one, defining it and being able to talk about it. And the second is with the research and data. I think we have pieces, right, of what we know about when we have family members in the room, how it can help improve patient health outcomes in general. So I do think that would be the biggest part of it, is just to be able to talk about it in a way that really jives with how people think of, how do I articulate this? Kind of using their language. And I guess to back up for just 1 second is I say that comment because I think about so much of what I've been learning over the course of like the past 10 years is, you come at it from a different framework, but you're really not going to be able to communicate effectively with this other context if you don't know their language and can't be on that same page. So I think it's important for us to define what it is, why it's important through deep data and research, and then to have those conversations.
Mm-hmm. Good point.
Mm-hmm.
And I think, honestly, specifically in specialties that are not family-centered within the healthcare systems, I think expanding, viewpoints, lenses to incorporate the family system could feel very daunting. And I also think, too, that depending upon the specialty, expanding that perspective and incorporating that more into their practice may or may not, they may not see the benefit of it. They may not, it may not be money making. And so, rather that expanded perspective and approach to healthcare, it's more cost effective, cost efficient. But that's still not leveraging as much attention as it should ideally, I think, within most healthcare systems. And so I think that, continued research and data that's available to identify why it is effective for all specialties is important.
Mm-hmm. Yeah, those are definitely good levels to think of. I mean, we think of financial, operational, clinical areas in our sense, but even all of us as on the call as instructors, providers, then there's healthcare administration and a lot of different groups that are involved in this whole thing. So if you don't mind, let me expand this question to the group. Just I'm curious to get other people's thoughts as far as this, why you hear, maybe it could be your site, your region, across the country, why family-centered care and family-centered teaching skills, are we advancing as well as we should be? Are there still some big barriers as far as what we need to do to overcome them? I'll throw that large question out there.
I can jump in. I think we have come a long way. I think the field is picking up steam. I think for a while, family-centered care was kind of lying dormant for several years, and at least within CFHA, I think there's been more energy and attention around it. Moving outside of CFHA, I think that we as proponents of this type of care have to really be good at advocating for it, speaking about it, talking about it, And that's something that I know that I struggle with. But there are a lot of people who, because of all the other things that are happening in the healthcare system, they just don't know about caregivers. They don't know about the importance of involving other family members because they're thinking about other things. And so that's part of our role is to talk more about it. The second thought that I have is I think we have a better sense of the kind of skills that medical learners need to have when they're engaging families, when they're identifying family problems. What I think still needs some development is designing the delivery systems to support these skills. So using health information technology that captures family-related data, having workflows and protocol that support having a whole team approach to working with families, having reimbursement models that make it easier to make this kind of work sustainable. That kind of larger system development still needs to happen. But I think for a while we've known what are the right questions to ask families, how do we engage them, what are some of the common problems that they're dealing with. I think we've known that for a while, but now we need to develop the systems that support that kind of work.
Yeah.
I absolutely agree with that. Yeah, for sure. Because that's going to get broader systemic attention.
Right.
From healthcare, globally speaking. Mm-hmm.
Yeah, and I don't know how much we emphasize that enough. Well, I'm sure not even in a lot of residency programs, but even in graduate training programs, we think about how the financial and incentives piece really comes into play. Because I don't know about all of you, but when you kick up from level 4 to 5 integrated care, I mean, you're really having to buy into a team approach where it's going to take a little bit more time for visits. It's going to take a little more time to see the family. But if physicians and others are under so much pressure for RVUs, for productivity to get stuff done, are we seen as a benefit? Or are we seen as the barrier? So we come across, but it could be a whole nother webinar. But any other thoughts or perspectives as far as why there's challenges, or I mean where we need to go? Because I know Larry gave a talk a while back on the research in family-centered care, and I know that's been talked about as expansion and ideas that we need to really also produce out there to show outcomes.
I think for me, what I found so far in my 1 year as a behavioral health faculty at our program is figure out what's simple and what works. I know our residents and our entire system's been built around 15-minute appointments, high productivity. And so I try to be very sensitive to the time constraints. And so for me, incorporating family education for them is about incorporating family within the interventions. And a lot of time it comes to engaging in social supports and behavioral activation with family members. Who's your exercise buddy? What about that uncle that lives down the street? Can you call your mom 3 times a week just to do something? So I try to find my little victories, and that's where I found I've had some success so far.
Yeah. Small.
Max, this is Hernan. Can you hear me?
Yeah.
Okay. First time using this computer. Hello all. I think that for me, the another level of complexity to really teach family interviewing here in the residency is that there is not so much literacy about mental health in general. So when you add the family element, most of the people think that this is another level of complexity. So, even when I go with some residents to the room, like Lawrence says, first to talk about behavioral activation or behavioral change first, and they don't have so much clues about that. So to add the family element, most of the time, I think that involves another level of complexity. And most of the time, these guys try to reduce complexity, not to increase complexity, because they have to do so much in a very short time that I think that they see it not so much as a benefit. So what I am trying to do is like to make a philosophical change first, and try to work from the frustrations that they have. For instance, when patients are not following prescriptions, you know, and I'm saying, okay, what is going on in the family? And then we involve the wife, and we are saying that she doesn't change the diet for a new diabetic patient. So I think that the working from the impact and not so much, you know, for the, adding another level of complexity. And this one, in a couple of years, I tell you if this works or not.
Mm-hmm. Yeah, that's a good point. I mean, we're trying to merge worlds, especially from at least majority, or actually all of us on the call, in the you know, the behavioral health or psychiatry world into, you know, the family medicine or merging different fields. It's definition.
It's true. I am also teaching family interviewing to psychiatric residents. I am finding very similar barriers to family medicine, actually.
Yeah. It's true. And I'm thinking, you know, Matt and I are working on a project of defining family centered care and just across disciplines. And I think it's been fascinating looking at the research, how families defined across psychiatry, nursing, family medicine, behavioral health. So I think our interpretations, I often wonder if, you know, we're bringing our lens and thinking everyone has to fit into it when we really have to adapt a lot. But
can you folks hear me? Okay.
Yeah.
So I agree with everything that's being said. I think it's very complex. I think the financial barriers in our system are enormous. You know, it's a structural issue, because I've seen in other countries, you know, just that don't have those structural barriers, it's a lot easier to get things going. The other thing is, I think, is the mental health disciplines. I mean, I'm a psychiatrist, so I, like Hernan, I've taught residents a long time. It's the concept of family. I have used the more of family sensitive, because if I get into family centered, it's a bigger paradigm shift. So how can you, in very small ways, so it's not just the levels of intervention, but, you know, in small ways, how is family included? One of the things I've done, I don't know, I don't know if it was Laura or Ruth earlier on, for medical students, I think one of the things that's really important is if you can tap them into something they've experienced personally. And for a long time when I taught medical students, there was one lecture I gave which was more on multi-generational, but it was really kind of the shared experience. And if you can get a medical student to focus or think about a personal experience, a grandparent, or they've had an illness, whatever, and just how it's impossible not to think about family and that, I think that's one way. Again, that's not a structural thing, just how to get people sensitized. The other thing I've done with medical students early on, I did this years ago, was for a medical student to interview one family for, you know, like 7-8 times. Just that it was to go out and meet the family that's dealing with a chronic illness and to learn about their experience. Again, that doesn't get into a curriculum issue so much directly, but it sort of keeps them awake about that. But I would say the financial, I think Max, I just think the financial structure and the diagnostic structures are so powerful. And psychiatry has its own turf on this, so it's very hard, even if you get them to agree that it's important, there's a relinquishing of power in this that I think is very hard. And if you have a small pie where everybody's grabbing for this small piece, you get turf issues among mental health professionals. I know we've all talked about this ad nauseum, but unfortunately in my career, I've not seen, in some ways it's gotten more rigidified, at least in my own discipline. It's given where I started my career, which is a long time ago. So anyway, I'm sorry I went on.
No, that's okay.
No, I wanted to follow what Sean says. In Argentina, there are the same CPT codes that you use for individual therapy. You can use it for couples or families, and they make a big difference in terms of the type of intervention in comparison to what's happened here in the States, that we don't have CPT codes for families now. So for insurance purposes. So I think that this is a huge barrier.
Mm-hmm. Right. John, just I wanted to go back and just observation. I think your camera might have froze, so you may adjust that. But we can still hear you.
Okay.
Well, you said you didn't use the term family-centered. You used.
Well, more family-centered. I mean, there's family-oriented, family-sensitive. I just think they're family-centered is a bigger I was responding to Hernan. I mean, if you're a psychiatrist and I tell you I'm interested in family-centered care, I'm asking you to make a huge leap. That's, I think, maybe not for family physicians. I think that's a different story.
Mm-hmm.
But I think for mental health psychologists, most of them are all pretty, individual. And so when you talk about family-centered, you're setting up, I think, a bigger feels like at times a confrontation. That's all.
Right.
So it's a little bit of language. I don't think conceptually, I actually am believing it should be family-centered, but I'm trying to think how to make it not such a big shift, and also for medical students. So
right.
That's what I meant.
That makes sense. Yeah.
The way I'm conceptualizing it is patient-centered care involves sensitivity to the family system.
Right. That's good.
I like that. That's really good. CJ Peak would be really proud of our lexicon discussion right now. So getting the A+ for him. Yeah. Well, yeah, it's true. I mean, it raises, 2 points I heard through this is, how you describe the terminology to other disciplines really makes a difference. And again, how our lens matches theirs. But the other point, not in kind of the defeatist mentality, but how, maybe we need to sell this more outside of just our healthcare system, and what administrators, what insurance companies, what larger levels need to know about the value, and are we really targeting the right areas in our healthcare system? Because obviously we can all do only so much in our capacity based on how busy the 9 of us are, but it's kind of hitting larger structures when I'm been hearing a little bit from people.
Yeah, and one thing
is kind of how do we do it?
Well, and just to add on, it's always just looking around, what's our inner circle. And I'll say that I've been so grateful to be able to work with this dual boarded family medicine psychiatrist here at UCSD, who is just kind of one of those champions, right, of behavioral science and family oriented care, family centered skills. So I think looking inner just hopefully will help us along the way as we're looking to those outer pieces as well.
Mm-hmm. That seems like a good buy-in. With conversations. Yeah, it's a large challenge, which I know will take quite a bit of time, but I'm glad, at least with CFHA, with the conference, been starting to talk more about not only reimbursement models a little bit more, but just from higher level impacts for outcomes of care. There's been more talks with that, which has been really good. But yeah, it's again, a whole nother topic and a whole nother conversation in itself. So I know we're almost up against the clock here. Any final thoughts on the topic, or some good reflections from the group? I don't know if there were any other final points on this.
It's a great discussion. Good discussion. It's important that this conversation continue.
Right.
Yeah, and I think just to again put a plug in for CFHA, with your first question, you asked us to describe your background, training, experience, and learning these skills. It is so essential as well as necessary that conferences have these types of sessions, because a lot has changed over the past 10 years. I don't know if I knew how to implement family-centered skills, without the help of these sessions along the way that do come up at these conferences.
Yeah.
Yeah.
That is good. I'm sure Jackie would approve our advertising as well for the conference.
Anytime.
I do appreciate it. Thank you.
So I guess just kind of wrapping up here, again, we'll have our closed meeting next month. There's a little bit of feedback here. Yeah, we'll have our closed meeting next month, and then the last open one will be in September. So we'll let you know around the topic with that. Get some really good information, not only with the webinar for people who couldn't join us but watch this. I would encourage for people out there listening to this, just more conversations around this I think are good. Not only at the conference around panels or debate style too, but even some subgroups on how we can tackle this issue, because the teaching is one thing, but how we really put into practice, that's a whole nother level that takes a lot of different professionals involved in that. Yeah.
I just had a question about where the recordings are posted. I know the annual SIG webinars that we put on are posted on the CFHA website, but I couldn't find webinar recordings of our membership meetings. So for example, the one that Larry Mausch helped lead last time, I couldn't find where that was posted. So I'm just wondering if maybe I dropped the ball somewhere, or if there's something.
I don't, if Jackie, if you're still on, was Leanna going to be working on that on the website?
Yeah, Liana usually does that posting of that stuff. So I was just taking a look for it too. And I will find out and send an email back to you guys, because it should all be posted. I'm just not sure where.
Okay.
Yeah, but if you send me the link, I'll make sure it gets posted, and I'll find out where she put it.
Yeah, that would be great. I think that would be a good page, and thanks for the reminder, Matt. There has been some requests for Larry's talk to go back. So that was another great webinar as well. So, but all right. I'm sorry to keep you over a few minutes, but good discussion. Again, Laura and Ruth, thank you.
Thank you.
On the fly for answering the questions, and great discussion. Hopefully we can do more of this at the conference, and we'll see all of you hopefully in the open call in September.
Thank you.
Take care.
All right.
Thank you.
Thanks a
Bye,
lot.
everyone.
Have a good weekend.